Why don't we get started? 8 o'clock. So good morning, everybody. Welcome to Department of Medicine Grand Rounds in the era of COVID. I also wanted to wish everybody a joyous holiday weekend, whatever you're celebrating. I hope you get to spend some quality time with friends and family, whether it's in person or via Zoom or WebEx or whatever social media you use. So with that, I would like to introduce Dr. Betsy Trowbridge, who is, as you know, a Packers fan and head of general internal medicine, to introduce our round speaker in a very timely topic. Betsy?
Great. Well, thanks, Lynn. So I am really honored today to introduce Dr. Mariah Quinn, who is an associate professor of medicine in the Department of Medicine and in my division of general internal medicine. And I'm going to tell you a little bit about her. And I also want to thank her for pivoting her Grand Rounds talk to really being specific to some of the things that we're dealing with today. So Mariah, I think that also goes to her expertise and national reputation in this area, that she could just make this talk so perfectly timed for us. So Dr. Quinn did her medical degree at Weill Medical College of Cornell University in New York, New York. She then went on to do her residency and internship in internal medicine and primary care at the Brigham and Women's Hospital in Boston. She followed that with a general internal medicine fellowship, and during her fellowship time, she got her master's of public health and clinical effectiveness at Boston Public Health at the Harvard School of Public Health. So that's fantastic. A little bit about her is she initially practiced, it's hard for me to do this in my normal way without, sorry about that. She practiced initially at Harvard Medical Associates before joining us in 2012. And really from the very time she joined us, she knew that her area of expertise was going to be resilience, empathy, and wellness. And she holds several leadership positions, one of which she came with when she joined us. She is an associate program director for the residency program, and she is also the director of humanism for the residency program. And she has developed a very interesting and innovative program for resilience and wellness for all of our residents that we are spreading into different areas of our institution now. And in 2019, which was last fall, she became our first director of provider well-being for the Department of Medicine, and was one of the inaugural members of the UW Health Provider Wellness Committee, which has been really very active over the past 2 years. You know, I always like to talk a little bit about people's honors and some of the interesting things that they've been awarded. So Dr. Quinn became a fellow in the ACP in 2016. And in 2015, she received the Graham Meyer Teaching Award for her excellence in ambulatory teaching here at University of Wisconsin. And just last year was awarded the Resident Wellness Award from the residency program. One really giant feather in her cap is that she was accepted into the Chief Wellness Officer training at Stanford University this past year. That's a very difficult to get into, and it's run by Tate Shanafeld, who is one of the leaders in wellness and burnout throughout this country. And so I'm really very happy to have her at our institution at this time when we really need her, talking about ways to mitigate our stress. Mariah, thanks.
Betsy, thank you so much for that introduction. And Lynn, it's probably fitting that we're talking about quarantine as we all sit in our home offices or physically distanced from others in workrooms. As I thought about giving the talk I was planning to give today about general updates on the literature about well-being and about our survey data from last fall, COVID really started to ramp up, and it just seemed like the time was right to think about doing a little something different. So I am going to have us start by just taking a watch and a listen. See if I can make my doc go away. Oh, guys, I'm sorry. I perhaps can't. Oh, it went. All right, here we go. So for me, this clip really highlights this intense human need we have to connect, even across physical distance. So Maurizio Marcini began to sing from his balcony in Italy every evening to his town. And with all we're facing right now, I think the bright part of that is our humanity as it comes out and we work to connect across distance and time. So since we are probably all alone and have many, many things on our minds, I'm going to ask you just to do one little thing for me, which is just to take a few deep breaths and let yourself become aware of your surroundings. As you do that, you might notice your heart rate slows a little bit and you become a little more comfortable. So it would be probably not right to acknowledge that many people who are watching this have actually experienced isolation or quarantine, and we'll define those terms in just a moment. So many of us here today, virtually, know some of what this experience is like for ourselves. And of course, everybody watching is facing physical or social distancing and has a sense of what that's meant to themselves. So probably there are a lot of ideas and feelings already in the audience that will inform how you perceive what I'm about to tell you. So next, I'd like to share with you a quote. This is used with permission from a friend of mine who's in Seattle. And here she says, "My spouse is on the front lines caring for patients in the ICU with minimal PPE because it's all gone. I took a leave of absence from work because I'm immunosuppressed and at high risk for complications, and we can't both be sick at the same time. I'm home today feeling like a total coward for abandoning my colleagues and my profession to this monstrous pandemic, but nobody needs a surgical X right now. My husband is sleeping and showering in the basement so he doesn't expose us. My kids are out of school for 6 weeks, and all I can try to do is keep everything as normal as I can. I want to scream." So my objectives for us today are to understand some of the pertinent vocabulary because the words that we use when we talk about this can get really squished together. We're going to talk about some of the immediate and longer term psychological impacts of quarantine on lay people, but also specifically on healthcare providers. We're going to delve into the stressors of quarantine and some of the factors that can be used to mitigate those. And then I am going to spend some time at the end of the talk thinking about organizationally how we can mitigate these factors, but also to hopefully empower you personally to have some tools to weather this more effectively so that you can be resilient and really function well when you're at work, et cetera. So just a little bit of history about quarantine. So the word first came about derived from quarantinaria, which was a 40-day period of isolation separating patients with leprosy from others, first mentioned in the 1100s in Italy. And quarantine has really been used to control the spread of infectious diseases throughout history. So notably the plague in the 1300s in Italy and then in England in the 1600s. But it's really been used to control the spread of a lot of illnesses, TB, diarrheal illnesses, even periods of quarantine for patients with HIV/AIDS in Cuba in the 80s and 90s. Quarantine has been a broadly used tool. There's some interesting historical literature about quarantine from the 1600s in England, which really show that some of the language around quarantine at that time was very similar to what it is now, which is that their altruism was really sought. It was touted as being for the public good. But underlying that, especially sort of on the ground, there was a counter narrative that quarantine was perceived as punishment. And you may hear some of those themes come up as we talk about people's reaction to quarantine. So the way that we really understand and use the term quarantine now is that it's the separation and restriction of people who have potentially been exposed to a contagious disease to ascertain if they become unwell, so reducing the risk of them infecting others. And so typically it applies to people who are asymptomatic. And it differs from isolation, although those are sometimes used interchangeably, especially in lay settings. And it can be done at home, like self-quarantine, or in a controlled setting, such as a quarantine center. It could be a dorm, it could be a hospital, etc., hotel even these days. So isolation is more specifically a healthcare term typically, and it really refers to keeping people with an infection away from those who are not infected. Again, it can be done at home or in a healthcare setting, and people typically use PPE when interacting with and caring for people on isolation. So this is from the COVID-19 Hub on UConnect, and this really summarizes kind of how to think about isolation for our patients. So quarantine is listed on the very bottom. So it's for people with no symptoms, but with close contact, like a family member or a roommate who is diagnosed with COVID-19. And here it summarizes our recommendations for them. All of the other lines of this, the other rows, actually refer to isolation. So that can be a person who has COVID-19 positive test, either with or without symptoms, someone who has not been able to have testing but has symptoms consistent with COVID-19, or even someone who has consistent symptoms but with a negative test. And that one really arose, especially at the beginning of all of this, because the sensitivity of the test has been a little bit of a moving target and a question. So let's talk about social distancing for a moment too. Social distancing is certainly on everyone's tongue, a term that I think most people would not have thought of even a couple months ago. And social distancing is really deliberately increasing physical space between people, again, to prevent the spread of illness. And it can look like kind of specific directives, like staying 6 feet apart, or we could make that a farther distance apart, working remotely, restricting gatherings greater than a certain size. As many of you probably saw in the news over the past couple of days, Governor Evers has now closed many of the state parks because so many people actually were going to the state parks as a way to kind of get out of their homes that they became overcrowded. It was difficult to enforce social distancing. So social distancing is all over Twitter. Here's some sort of medical educational content. Here's some less educational but rather humorous content. Ozzy Osbourne is apparently immunocompromised, and here he is social distancing in a cloud of Lysol. And these bassets are not practicing social distancing. Thank goodness we can be with our pets, we've learned. And even generational humor has taken over. So as a Gen Xer, I find this sort of funny, but even I find social distancing a little bit difficult. So many of us have seen this figure and seen these models, which were published in the Washington Post and really got a lot of traction on social media as a way of demonstrating why people should socially distance, along with, sort of the concept of flattening the curve. This has really helped us actually change the modeling for the trajectory of COVID-19 in many places around the world, but specifically here in Wisconsin. So just to summarize, quarantine is for people who are at risk of infection. Isolation is for people who have the infection based on clinical or test positivity. And social distancing is for everyone. So it's a huge public health intervention. And all of them are intended to reduce transmission risk, either absolute or potential transmission risk. So I want to go back to my friend's quote, and she is doing okay, by the way. We've been sort of talking regularly via Facebook. So in her quote, you can really see hallmarks of social distancing. Her kids are out of school. She is no longer going to work. For a period of time, she was working remotely and then took a leave. And you can see her husband engaging in something that looks a lot like quarantine when he's in their house, because he has known exposures to COVID-19. And so when he comes into the house, he doesn't interact with his family. He stays on a different floor, etc. He has remained healthy, thankfully. So I'd like to transition a little bit into thinking about how people react when on quarantine. And I imagine that many of you, as you've either been on isolation or quarantine for either a day or up to a week, kind of earlier in this period, have a lot of ideas about this. This sketch is from a series of sketches done by a Chinese artist named Jing Li, which really show sort of the experience of being on lockdown in Hubei province in China. They were published in the Washington Post. I'd really encourage you to look at them because they're very evocative. But thankfully, there's also some evidence to guide us. There was a rapid review published in mid-March, actually, in The Lancet. And this was a review that looked at papers including the search terms quarantine or patient isolation, as well as psychological outcomes terms. This came at the perfect time for me to start planning this talk, so I'm very grateful to Brooks and co-authors. They ended up with 24 articles for inclusion, and these included articles that looked at 5 different disease states, including SARS, MERS, Ebola, H1N1, equine influenza, and one study that looked at a combination of SARS and H1N1 outcomes. There were a mixture of quantitative and qualitative methods in the studies that they included. And they really were focusing on the psychological impacts of quarantine. Now, As most of you probably imagine, the majority of time being isolated or quarantined is not a particularly positive experience. But actually experiencing some relief or joy can certainly occur and can be a component alongside other emotions. So here's a quote that represents that experience. To tell the truth, when they isolated me, I was so free. I stretched out alone whenever I wanted. I talked about this and that. I watched TV. Basically, I did anything I wanted. And this is from a midwifery student during an Ebola outbreak. A quote to represent more of the sort of usual experience is this one. I can say that it was hard for me when I was isolated. Staying shut in for days is hard, with my own bottle, my own spoon, everything cut off. There's a 1-year-old child in my house who's attached to me, but I had to run away from him. And the emotions and feelings listed on this slide are much more common reactions. So I want to turn some of my attention to specifically look at some studies that related to SARS-CoV-1 in 2003, because they can tell us a lot of what we sort of understand now about the stressors of quarantine and how we might actually then go about mitigating them. So one of the factors that's been seen to be very important in terms of how people fare with quarantine and isolation is duration. And it might stand to some reason that the longer you're quarantined, probably the worse the emotional impact will be. And multiple studies actually bear that out. So you would be right if you guessed that. And just for a little context, looking specifically at Toronto, in 2003, during the SARS-CoV-1 pandemic, more than 15,000 people had an epidemiologic exposure to SARS and were instructed to remain in voluntary quarantine. And the directives they received are going to sound very familiar to us. And in fact, they overlap a lot with our general social distancing recommendations. So not taking visitors into the home, no leaving the home. And that of course is sort of the hallmark that really separates quarantine from social distancing, is that greater constriction of liberty. Washing hands frequently, wearing a mask if in the same room as other household members, not sleeping in the same room as other household members, not sharing personal items. And then this one will sound very familiar to all of us, instructed to take their temperature twice a day. We're doing that for self-monitoring. Later in the pandemic, while this was initially a voluntary quarantine, people who were quarantined were actually checked in on by the public health department. And if they were not reachable, receive a home visit or a legal order. So over time, as the SARS epidemic went on, they started to tighten the quarantine requirements. So I wanted to talk about the first study looking at psychological outcomes after SARS-CoV-1. And this was done very shortly after the quarantine period ended. And it was a study that was done basically by posting advertisements that people could participate on the media, as well as in high traffic places like libraries and supermarkets and healthcare settings. So you can imagine that's probably not the highest yield way to administer a survey, but that's how this initial survey was done. And it was a 152 item survey, which sounds like a lot, but it took about 20 minutes apparently. And they ended up with 129 respondents. So a very low response rate when compared to the total number of people under quarantine. It was sort of an interesting group of respondents too, because 68% of them were actually healthcare workers. 72% had a college education or greater, 58% were married, and actually on average, it was quite a well-off survey or population. So probably not terribly representative of the general Toronto population. They looked at symptoms of PTSD and depression using the scales listed here, the IESR and the CESD. So the outcomes they found in this very small number of survey respondents were PTSD symptoms above their threshold in 28.9% of respondents, a very significant proportion, and depression in 31.2% of respondents. And they found that there was an inflection point around about 10 days of quarantine at which the likelihood of PTSD symptoms went up substantially. As I said, there are some generalizability concerns with this population because it was such a small group. They in general were highly educated, generally well off, and disproportionately represented healthcare workers. To me, that is interesting because I am specifically interested in how all of we are doing as healthcare workers, but wouldn't necessarily tell us as much about the general population, how to mitigate quarantine stressors for everybody. They did find in their sort of sub-analyses that when they looked at different income brackets, that the lower income folks in the sample fared substantially worse. So we should keep that in mind as we go forward and are caring for our patients. So So I wanted to talk about a second study that was done that did get a more of a representative sample. So this was also in Toronto, and this one, as opposed to being about a month after quarantine ended on median, was administered 3 months afterwards. This was a mail-based survey to people identified in the public health database as having experienced quarantine for at least 2 days. And they had a decent response rate of about 55%. And here again, they used that same scale with the same cutoff looking for PTSD symptoms, and they found a prevalence of PTSD symptoms of 14.6%. So, it's possible that this was just a better sample, less prone to bias. Also, this was 2 months later in most cases, and so it's possible it represented a waning of symptoms. But interestingly, one of the notes from this study is they asked people how long they were on quarantine, and they could compare that against the public health records. And what they found is that people in almost all cases overestimated how long they'd been on quarantine. That could, of course, mean that the record keeping was in some way faulty and didn't line up with the reality in people's homes, or it could mean that they simply recalled it as being bigger and longer than it was. A second significant stressor in quarantine is fears of infection, whether that's getting infected oneself or the fears of infecting others. Now, because quarantine typically is thought of as being for people who've had, a reasonable likelihood of exposure to the disease, this is, of course, a very reasonable fear. But being on quarantine under otherwise equal circumstances really increases the fears that one is going to give the infection to someone else. One pertinent point, and this is data from the MERS epidemic, actually, not SARS-CoV-1, is that developing symptoms suggestive of the infection significantly increased anxiety and worsened psychological outcomes. And this sort of anxiety and worsening outcome actually persisted for months after the quarantine period. This is, of course, really pertinent to our situation now because COVID began for us during flu season still. So we had a lot of people who were ill with respiratory symptoms that were very difficult to distinguish from COVID-19 clinically. Now it's spring, many people are developing their seasonal allergies, they have sniffles, they have sneezes, their asthma might be flaring. And so all of this in this time of social distancing really serves to augment people's anxiety that they could be ill or transmitting COVID. Two groups that during the H1N1 pandemic were seen to really have a heightened fear of transmitting the infection to others were pregnant women and parents with young children. And I would say experientially and anecdotally, in this current situation, we're really seeing that same pattern. And then one last point that I think is important and pertinent to kind of the media and social media landscape we live in now. Media coverage of deaths due to infections has really increased fears of infection significantly. And that increased fear heightens anxiety. And some of that media exposure and attention can actually worsen people's psychological outcomes without providing them with additional benefit. Boredom and frustration are significant emotions during quarantine and isolation, and factors that lead to those feelings specifically include loss of routine, just being physically confined, reduced social and physical contact with others, and just a sense of isolation or loneliness. And as we know, loneliness has been shown in the literature to actually itself be a negative marker for psychological and physical health. Interestingly, loss of ability to just do usual activities like shop for your own groceries actually have been seen to be significant factors in amping up these emotions. And of course, inadequacy of supplies and inability to access healthcare has really increased frustration and anger. This is one of the reasons I'm so proud of our institution for really ramping up our ability to do telemedicine and video medicine and things like that. So even though we're trying to keep our patients out of our clinical environments, we are trying to continue to create ways to evaluate them, take care of them, et cetera, because long-term, that's really going to be needed. Some data from the MERS epidemic would also suggest that some of this can be ameliorated by access to telephone and internet. I would just, of course, caution that if the internet is used only for reading frightening news, it might be expected to counter that benefit. Additional stressors of quarantine include lack of understanding and onerous quarantine requirements. So lack of understanding can be related to lower educational attainment or health literacy, but also just poor, unclear communication on the part of organizations, public health requirements, government. And I do think we certainly are living in a time when there's a lot of fluidity to what we're telling people. And being able to do that sort of calmly and consistently is very important. I personally, as a healthcare worker at UW Health, have really appreciated the sort of even-headed, consistent communication we've gotten from our leadership, and especially exemplified by Dr. Nasia Safdar. In terms of onerous quarantine requirements, I would just reference the same study we talked about, the Mayo survey to 1,912 adults in Toronto 3 months after their quarantine ending for SARS-CoV-1 in 2003. And they actually reported that the most onerous part of quarantine was not leaving the home to visit friends or socialize. So it wasn't the infection control, it wasn't the temperature taking for most people, although there was one respondent in the prior study, the media-based study, that reported that they would panic every time they took their temperature. But in general, just being confined and not being able to be with people was really considered onerous. And I think many of us have worries about that and have been experiencing that, especially as we hit holidays, where typically we would be physically with our family members or friends. As we experience difficulties, we can't do normal things like hug one another. That physical proximity that we typically thrive on as humans is not available to us right now. And so I wouldn't underplay how important that is. Financial strain is a very significant stressor for people on quarantine, and I'm sure many of you have been watching the news about the unemployment numbers as they've been going up over the past few weeks, kind of like an asymptotic cliff. And in a study of 300 workers at a printing company in Beijing during SARS-CoV-1, there was a survey that was done after quarantine was lifted almost 3/4 of a year later. They had a response rate of 62%, and they found at that time a screen positivity for psychological disorders of 26%. And income reduction was actually the greatest risk factor with an odds ratio of 25. So this is a really important consideration, of course, for everybody, healthcare workers and the general population. So just to summarize some of the stressors: long duration, fears of infection, factors leading into boredom and frustration, lack of understanding, onerous quarantine requirements, poor access to basic needs, and financial strain are some of the stressors that many of them we actually can do something about. So this is also from my friend in Seattle. I think this is maybe where all the toilet paper is. So there are a few other factors that just can predict poor outcomes, and these include prior mental health problems, lower income, lower educational attainment, and actually being a healthcare worker. And so I do want to spend a little bit of time talking about healthcare workers' experience of quarantine. So as you can imagine, as healthcare workers, we're pretty likely to understand the rationale for quarantine, and we're also quite likely to comply with quarantine recommendations. However, the bulk of evidence, not all of it, but the majority of it would suggest that healthcare workers are more likely to suffer emotionally. And some of that may be for reasons that are not surprising. We have tremendous exposure to suffering and illness. We know the tip of the iceberg. We know how bad outcomes can be. The healthcare role itself generally increases stress over the basic population, and you couple that with a situation like this, in settings where people get extremely physically and emotionally exhausted, you would expect that they would do worse. In the literature, it's typically been seen that nurses fare somewhat less well than physicians, and that may have something to do with the direct amount of time they're spending with patients. Also could have a gender component, as nursing has historically been more replete with women, and there is some evidence that gender plays in this as well. And then certainly it's been seen that healthcare workers in epicenter locations tend to do worse psychologically than those more on the periphery. Given the aggressive social distancing in Wisconsin and the sort of flattening of the curve and the time we've had to prepare, my hope is that we won't see some of the outcomes that may be expected in places like New York City. There is, of course, also a greater likelihood that we will be exposed and actually infected. But when you look at the evidence, being quarantined increases stress above and beyond those factors. Now, being quarantined is a major risk for acute stress reaction. And I just wanted to pause and linger on this for a moment, because I think one of the tasks for all of us as we go into the rest of this phase, however long it goes on, is to be self-monitoring, not just for symptoms of COVID, but also self-monitoring our stress and doing what we can to manage it and monitoring one another. So This is from the DSM-5, and I'm not going to sort of read every piece in the slide, but really to have an acute stress reaction, you have to have been exposed to an actual trauma. Now, epidemics are not usually included on the list of things that are traumatic, but seeing repeated suffering, seeing repeated death fall into this category. And then there are symptoms. So you have to have at least 9 out of 14 or more of symptoms in the domains of intrusive thoughts and feelings, negative mood, dissociative symptoms, avoidance symptoms, and arousal symptoms. And I included that section a little bit more because these are the types of things that most of us will be probably most aware of. So sleep disturbance, irritability and anger, hypervigilance, concentration difficulty, and exaggerated startle response. Actually, this description overlaps very strongly with another syndrome that's been described called second victim syndrome. And I wanted to sort of pull out these arousal symptoms because especially the irritability and anger component is something that we may feel in ourselves or we may see in our colleagues. And if we are feeling that or seeing that, that would be an important symptom to pay attention to. So coming back to healthcare workers, there's also evidence that there actually can arise conflict within families about the healthcare worker role enough to cause significant distress. This was really specifically seen in the Ebola outbreaks. Healthcare workers report greater stigma than the general public, likely because people in the public perceive their higher risk for exposure and potential infection and infectivity. In many studies, they've been seen to have greater lost income, and they engage in greater avoidance activities post-quarantine. And these can extend into the workplace, such as avoiding going and evaluating a patient who has a cough, for instance. That obviously long-term is not an avoidance that we'd like. And they have a higher risk of substance abuse and depression, even years after quarantine. So this is a table from the article that looked at the male survey we've talked about a couple of times. And so the top part really just summarizes the prevalence of a variety of emotions of people under quarantine. You can see happiness and relief are on there at a very low rate, but the rest of them tend to be more along the lines of negative emotions. But I wanted to draw your attention to this bottom part of the table, which is behaviors after quarantine. So this really shows some of those avoidance behaviors. And this was, a general population study 3 months after quarantine ended. And at that point, people were still fairly likely to avoid people who were coughing or sneezing. For some of us, that means avoiding our children, who seem to always be doing something like that. But also something that looks a bit like agoraphobia, avoiding public places, avoiding crowded, enclosed public spaces specifically. But you can see here that a fifth to a quarter of the respondents to that survey 3 months later were engaging in avoidance of those places. So that really hints that there is something about the experience of quarantine, and I would say this will extend to social distancing, even though it limits our liberties somewhat less, that makes the world seem less safe. And it would be reasonable to expect that it's going to take some time for things to sort of get back to normal. Many of you may have had the experience I've had of watching television or some old movie and being shocked when people interact closely with one another or share food or, kiss a stranger or something like that. These all seemed normal a couple of months ago. It wouldn't even have really crossed my mind. But now we note them. We observe proximity much more closely than we used to. I've certainly anecdotally had people tell me about dreams that it's the zombie apocalypse out there, sharing experiences of feeling that maybe they should go check out the outside world because it's just starting to seem unsafe and they should probably check that out. So, even we are having some really significant sort of just changes in our perception related to this. So stigma, which I mentioned previously specifically around healthcare workers, has been described in healthcare workers and lay people in quarantine. And it's really been shown that people who've been quarantined can experience an array of negative social behaviors from others, including avoiding them, withdrawing social invitations, making critical comments, or just generally acting suspicious or fearful around them. And you can imagine that when someone has been sort of involuntarily isolated or made to feel lonely for a period of time, coming back in the world and experiencing these would not be helpful from a mental health perspective. It's also just notable that in this sort of era of social distancing, in which we are really told that anyone who's out in the community should be considered infectious, that we are all at risk, that it's not surprising that we might see some very interesting behaviors. I've noticed when out walking my dog that even if someone is on the opposite side of the street, there's a tendency to avert their eyes. People often don't even say hello. And I think it represents this kind of worry. And I'll say, as a very non-threatening looking kind of petite woman, I'm not used to that kind of behavior. And so it's quite notable. So again, I think it's sort of a modification of how we feel in terms of our safety and vulnerability. So thinking about additional stressors after quarantine, finances again are a very, very big one. And studies have shown that support measures can help, but aren't always adequate, don't always come at the same time. And when there's significant financial distress, people do much less well. They have a lot higher risk of psychological disorders, anger, and anxiety. And this is going to be something for us to really watch in our surrounding community and our patients, et cetera. So I've been sort of dancing around this question and mashing together terms a little bit about social distancing compared to quarantine. And we don't have a lot of data yet about how social distancing is going to look compared to sort of true quarantine where people are told not to leave their homes. But my suspicion is that it will likely be significant, that people will have experienced significant isolation, significant anxiety, and there will absolutely be significant financial impacts. And we will be sort of seeing these sequelae for months, if not years to come. This picture, of course, is from the April 7th election from one of the, I think, 5 Milwaukee polling places, which really pushed people out of social distancing into physical proximity. From the angle of the photo, I certainly can't tell if people are standing 6 feet apart, but I'd guess they aren't. I do see a lot of masks, but it really goes to show how seriously people are taking the risk of transmission, but also taking seriously their attempts to engage in their civic duties. So that is a lot of heavy content. I want to transition to some degree to talking about mitigation strategies, and they really mostly align with the stressors that we've been talking about. So the first is keeping quarantine as short as possible. The second is providing adequate infection control, such as disinfection of clothing, making sure that when we tell people they're isolated, that we provide them with a mask, for instance, providing clear communication and education, provision for basic needs, shelter, food, means of communication. I was really heartened to see that UW Health published access to isolation and quarantine facilities for our patients who might be homeless or not otherwise able to isolate at home, financial support, reimbursement for lost income, allowing remote learning whenever possible, and then amping up psychological support. So these are some general strategies. Now, I do want to sort of reflect a little bit specifically on us again and how we might manage this, how UW Health is managing this. So when it comes to duration, isolation and quarantine duration has really changed over the period of our experience of this pandemic. So when this began, employee health was not staffed to a degree to take all of the many calls that came in, but they so rapidly redeployed and staffed up that now we're able to get someone in and out of isolation very, very quickly. And our test turnaround has gone way down. This has been an incredible effort that has really helped shorten our duration of this experience. Additionally, our return to work and exposed provider policies really keep us as much as possible out of quarantine and isolation and working and interacting with other people. Our PPE guidelines and sort of the attention to the evidence, the looking at ways we can conserve, reuse, and sterilize our PPE has been very impressive and will continue to be really important. You can find a lot of wonderful guidance on UConnect, including guidance on how to avoid infecting your family, what the resources are for housing for asymptomatic quarantine and isolation. So just to quick call them out, they're DeJope Hall and Lowell Hall on campus. Very purposeful augmentation of psychological support, which I'll talk about in a moment, and then really regular communication and information. You might even feel it's a lot. It's a regular stream of information that does change over time, but it is keeping us apprised of what is happening and what is best understood to be the right thing to do. In Department of Medicine, we also have our incredibly useful town halls with Dr. Schnapp, Dr. Sofdar, and guests, and those have been absolutely critical. And many of our divisions, including my own, have regular huddles that really review how we should be working, how PPE recommendations pertain to us, surge planning, et cetera. So, and these are of course all done remotely via WebEx. And I think that the use of technology and having all of us learn to do that really quickly has been critically important with helping mitigate some of the social distancing impacts we would otherwise experience. The university and the hospital have also really made us able to do a lot to socially distance from patients while still caring for them, and socially distance from one another while still working. Even in the inpatient setting, of course, we've seen changes with regards to policy on how many exams must be done. People can often do telephonic consultations even within the hospital, and I think that innovation has been just critically important. So what can you do if you're quarantined or isolated? And of course, isolation really specifically refers to the situation in which you're sick, in which you have coronavirus, because now we can test all of our employees and we'll know. And that experience could range, as you know, from simply losing your sense of smell to really feeling extremely horrible. But if you are on isolation and you sort of feel okay, there's a lot you can do to kind of support your psyche and your emotional health. So one critical thing is just continuing to have a routine, getting up in the morning, taking a shower if that's your normal time, getting dressed, even if you really like your pajama pants, maybe putting on a different shirt. Just having some routine can help mitigate some of the stress of being isolated. And then the creation of meaning. Healthcare workers in general tend to be a very meaning and purpose-driven group. And if you can continue to work remotely and participate in your work in that way, that can really help. But if you can't, or if you're too ill, there are other ways to create meaning, such as journaling, gratitude practice, making art, all kinds of other meaning-making strategies. I would just say as well that avoiding coping that's going to be unhelpful is also important. So it's easy to find social media helpful because we connect to people, but it's also easy to find information there that heightens our anxiety or foments anger. And just sort of being intentional and thoughtful about how much of that you consume is really important. Another thing we probably should not consume too much of is alcohol for coping. It actually makes mood worse. It worsens sleep. Just not a great choice for us right now to go beyond recommended limits. And additionally, I would just say use all of your well-being strategies that generally help you. Exercise if you feel well enough, even if it's very gentle. Mind-body techniques if you use those. Seeking support, and then really staying connected. So this is a group of women from my clinic. Hello, all of you. We had a Zoom check-in a week ago. I missed one last night, but it was just so wonderful to be with my clinic ladies. So when it comes to psychological support, I really wanted to highlight what's been done here over the past several weeks, which includes the creation of 3 new sources of support. So this is a resource sheet that was sent out, and actually it is mildly out of date already, and I'll tell you how when we get to that part. But at the top, you can really see the crisis 24/7 availabilities for psychological support. It would not be shocking. I hope it doesn't happen, but it would not be shocking if one of us finds ourselves in the situation where we really need some urgent help. And those are ways to get that 24/7. The columns then sort of illuminate sources of support that we've either had all along, like the Employee Assistance Office on campus, wellness options at work, Life Matters. It gives you all the contact information for these, as well as clinician and health coaching. And this still remains a very, very relevant source because it can really help you navigate within yourself how to increase your health behaviors and resilience behaviors at a time when we need those more than ever. Now, these 3 columns here represent the new offerings. So we heard at our town hall on Wednesday, and I've heard a little bit in our vital signs and on the COVID-19 communications about the debriefing and support groups, which are coming out onto the units led by behavioral health and psychiatry. If you haven't seen those, you very likely will start to see those. It sounds like those are going to be a standing offering, and I've heard that they've been very helpful for those who've experienced them. The psychiatry and behavioral health stress management line is also new. It is actually now available 8 to 8. So if you're home in the evening and feeling overwhelmed or just feeling like now is the time I could call someone and talk to them about how I'm not sleeping, absolutely call that number. What happens when you call that number, which I tried out myself to see what would happen, is you get a triage person on the phone and they warm connect you with one of the UW Health therapists. So within just a few minutes, I was speaking to one of the very kind therapists who spent a little bit of time with me. We reviewed a strategy I'd forgotten for falling back to sleep when waking up. So I would really encourage you to use this. It's free. It doesn't go in your medical record. It's confidential. Absolutely use it. And if it turns out you get on the phone with that therapist and you actually need a little bit of a higher level of service, the therapist will help make sure that you are matched with the appropriate person and that you get what you need. So please use this. The last new resource is the UW Health Peer Support Program, and this is really support from a trained peer. It's confidential, legally protected under peer review privilege, and it's for clinicians, people sort of serving on the front lines in care, so that could include people like respiratory techs and others. You can access it by emailing peersupport@uwhealth.org. We will also be doing some peer supporter rounding on some of the higher need units. This will probably start mid next week as we start to work through that workflow. You can also directly approach a peer supporter and talk with them. And over the next week, I'll start to publish the DOM peer supporters and the full list so you know who they are. I just want to really thank those of you in our department who put yourselves forward to be trained and have completed the training. Getting this program up and running over the past 3 weeks has been an incredible team effort. I was lucky to work with Sarah Weber in pediatrics, Brian Sharp and Chris Vandevort in the emergency department, Corey Geisler, provider services, employee health, including Amy Mim, Megan Carls, and Ellen Houston. From risk management, Jen Rouser and Bob Ebby. HR has been involved. This has been an incredible team effort, and I'm so grateful to those of you who are interested and willing to be trained. And please use the program. Peer support programs at other institutions have been shown to be very effective in helping people mitigate stress related to bad outcomes and work stress. And a peer can sometimes be sort of easier to talk to in terms of context than thinking about behavioral health. But I would like to encourage you to use any and all of these. They are all appropriate in this setting. So this is where we've been. And then before we finish up with some time for questions, I have one more activity for us, but I hope that you now understand some of the pertinent vocabulary. You have a sense for what the immediate and longer term psychological impacts of quarantine are on lay people and healthcare providers, and some ideas about what we might predict could come out of social distancing. The stressors of quarantine and some factors to mitigate these have been discussed, and we've gone through how organizationally and you sort of as an individual can more effectively manage quarantine, isolation, and social distancing. So I am going to just segue here because I really, talking about employee health and the incredible work that they have done over the past month and a half, I didn't feel that I could go past that without acknowledging and honoring Beth Potter. For those of you who did not know this, Beth was she had a regular meditation practice. She was a teacher at the Institute for Zen Leadership. She really engaged in that sort of wholeheartedly and brought what she learned from that into her leadership and into her interactions with others. And so to honor Beth, I wanted to take us through a Zen practice called Strong Back, Soft Front. And this is borrowed from a Zen priest named Joan Halifax. So if you're not sitting, I'll ask you to do so, and I'm actually going to sit down as well. And just forgive me while I read this to you. Okay. Sit down in a comfortable position where you'll be able to hold still for some time, whether in a chair or on a cushion or the floor. After you sit down, slowly become aware of your breath and your body. Let your body soften. If you're sitting on a chair, relax your legs and put both feet flat on the floor. If you're sitting on a cushion or the floor, you can arrange your legs however is comfortable. Be present to the sense of gravity. Invite the groundedness of the earth into your body and mind. Let your whole body experience the strength of your stable connection with the earth. Relax into the firmness of this stability. Now bring your awareness into your spine. Breathe into your spine. Appreciate how vertical, strong, flexible, and conductive it is. Rock gently from side to side as you settle your posture. The strength of your spine allows you to uphold yourself in the midst of any condition. You can remind yourself of this strength by silently saying, strong back. Your mind and your back are connected. Feel the sense of uprightness and flexibility in your mind. Now let your awareness go to your belly. Breathe into your belly. Let your breath be deep and strong as your belly rises and falls. Feel your natural courage and openness as you breathe deeply into your belly. Shifting your awareness to your chest. With your mind, touch the tender, open feeling of this space. Let yourself be present to your own suffering and to the fact that just like you, others also suffer. Imagine being free of suffering and helping others be free too. Feel the strength of your resolve rising up from your belly. Let your heart be open and permeable. Release any tightness as you allow your breath to pass through your heart. Remind yourself of your own tenderness by saying, soft front. Now bring your awareness to your lungs. With your spine straight, let your breath fully enter your lungs. Fill your lungs softly with air. With gratitude, remember that your life is supported by each breath. At this point, your whole front of your body may begin to feel open, receptive, and permeable. Through your open body, you can feel the world, which lends compassion. Through your strong spine, you can be with suffering, which gives you equanimity. Let these qualities of equanimity and compassion intermingle. Let them inform one another and give you genuine presence. Strong back, soft front. This is the essence of the work of peace. Whatever sounds, sights, smells, tastes, or feelings arise, simply let them pass in and out of your awareness as you keep your mind on your breath. You are relaxing in such a way that you can begin to drop deeper into a place, deeper than your personality, deeper than your identity, deeper than your story, because it can be all stories, open to all stories. Strong back, soft front. When you've completed this simple practice, you can offer to others whatever good has arisen, so that you remember to bring the spirit of your restful breath into your everyday life in order to help others. Now, if anyone has their eyes closed, maybe wiggle your fingers and toes a little bit and feel free to open your eyes, and we'll come back together. I think we do have a few minutes for questions. Thank you very much.
Well, thank you, Mariah, for a wonderful overview of the topic, and for sharing information and for the tips. I really appreciate it, and I know everyone here does as well. Um, I don't know if you can get into the question and answer panel, um, or otherwise I'm happy to read it for you.
I think I can. So I will go ahead and read these as well. So there's a question here. I agree that the media has overplayed the negative outcomes aspects of this pandemic, but I think this also has helped people to practice social distancing. How would you suggest a better balance? Reporting on recovery too? Let me just make sure there's not more to this question. Let's see here.
That's it.
Absolutely. Okay. So this is a really good question, and I've actually been thinking about this quite a lot. I'm not a media specialist nor someone who has a great deal of expertise in sort of balancing that, but I do think that people now sort of understand the needs for this. And so I think that, news is a business, and they make money by having people come back and talking about, particularly tragic cases gets people, additionally interested in reading the news. So I do just want to acknowledge that, media is really a business. I think that in articles about coronavirus, it would certainly be nice to see, some simple statistics about the likelihood that people will recover, et cetera. So reporting on recovery would be helpful. And generally also focusing on some of the positive aspects of what we're learning, not to minimize the negatives at all, but simply to call out some balance to that. I think Laura's second question, here we go. Although there are negative aspects of this experience, there are also some positive aspects that we can learn. How might we keep some of these positive aspects in our normal? I think that is a wonderful question. We are undoubtedly learning a tremendous amount that can help us later in terms of our patient care, like telemedicine, et cetera. I think a lot is going to change. But the other hopes that I have are that this experience is going to break down many silos between specialties for interest. Seeing the chairs working so hard together to work on the surge plan, for instance, if we can come together more effectively, this could have long-range impacts on our ability to work as teams, interprofessional and interdisciplinary teams. I also think that the new appreciation we have for social connectedness with one another and with our patients, we can bring forward with us. So I think there are going to be a lot of things that we will learn that will be these kind of strange silver linings that we'll keep. Let's see. I'm going to make sure I'm not missing any. Okay. Kimberly asks, many of us also have children at home. Can you talk about how the social distancing guidelines may impact them differently and what that might look like differing from the adult stress reaction and how to support them? That's a great question. So I didn't focus on that a lot, but what I've read to this point is that social distancing is going to be perceived quite differently under different circumstances. So kids who are quarantined or distanced away from their families absolutely do the worst. So keeping our family units intact whenever we can is really helpful. But also there's a differential impact based on age. So for younger kids, they actually seem to be doing quite well just at home with their parents, who hopefully are managing their work and the homeschooling stuff and everything else as well as they can. Whereas older kids for whom sort of their social network has become increasingly important, they are more likely to suffer loneliness and isolation. So as much as possible, helping them also retain routine, get exercise, not succumb to complete screen time, all of that stuff, the basic kind of health things that we're doing for ourselves are important, and helping leverage technology for them to remain connected with their social groups is really important as well. I've been heartened to see like some Zoom classes for my older daughter's online school instead of just, reading off the screen. And I think that could be leveraged more effectively, and we can help them do that as well. That's kind of a few ideas. Bennett says, thank you so much for championing this and searching for optimism. Might what we are doing now for wellness forever change how we care for health professionals? Bennett, thank you for that question. I was on a call with ACGME yesterday with, I think there were 500 of us there from different institutions. And I think the answer is yes. In the past 10 years, there has rightly been a real focus on what we can do from a systems perspective to improve well-being. I think now people are open in a way they haven't been before to talking about personal resilience and allowing us to bring offerings to them that will help promote that element of well-being as well. I also think that this has really forced just an incredible acknowledgement of the stress that healthcare workers are under and just the innovation around this, even just the examples of UW Health, that getting a peer support program up and running quickly, which generally is a very long process, behavioral health really stepping up to the plate to offer us more. I think that this will really change things going forward, and we'll see what kind of persists, but my hope is that yes, that does happen. Do you have access to the slides? I think you should. Yes.
Yes.
All right. Lynn, I'm just watching time.
Yes. And just another comment from Megan Newman, who recommended resources for families and pediatric providers at healthychildren.org. So thank you for that. And in the
Thank you, Megan.
In the interest of time, I'm sure Mariah will take any questions by email or WebEx. I really want to thank her for pivoting a little bit on this talk to make it much more timely. It was great timing on our part to have you scheduled for Grand Round. So I really want to thank you, and I want to thank everyone for being here. I hope you all stay happy, safe, and sane, and look forward to next week's talk. All right, take care.
Thank you so much, everyone.